Good evening, friends. Welcome to yet another ICS web meet. And today we have a very interesting topic away from interventions. Right now, we are more into the physiology of the lung. So, today the topic is all about lung volumes and DLCO from A to Z. So, without wasting much of the time, we will move on to the talks. But before that, I'd like to express my thanks to Schiller, especially Mr. Amit and Sipla for the academic support, Mr. Viranjan. And with this, we move on to the our talk. And today we have got some eminent speakers from across the country as well as panelists who are very close friends of mine as well as academically very strong to lead the panel discussion. So, if we can have the intro slide of Dr. Sumita Agarwal. So, Dr. Sumita Agarwal is a very close friend of mine and excellent academician and researcher. And she is currently working as a consultant and head in the Department of the Pulmonary Medicine and Critical Care at Jodhpur in Medipulse Hospital. She has been she has done her training even in UK as well, and then has done her DM in pulmonary and critical care from Safdarjung, and has got more than 37 publications in indexed journals. Apart from that, as we all know from who are close to her, she is extremely talented and knowledgeable, and she has a special interest in meta-analysis and other research activities. So today she will be with us to speak about DLCO indications and interpretation. Over to you, Dr. Sumita Agarwal, ma'am, for your talk.
So, good evening, everyone. Today we'll be discussing a very important physiological topic, which is important clinically. You know, when you see cases day to day in your clinical practice, and when we are stuck up at spirometry, we want to understand what details are happening. A DLCO, diffusion capacity of lungs, is where we what guides us into further understanding what's happening with the lung pathology over there. So let's understand DLCO. DLCO measures the ability of the lungs to transfer gas from inhaled alveoli into the red blood cells within the pulmonary capillaries. So what it is effectively telling us that how swiftly the oxygen is going across the alveolar capillary membrane to your pulmonary capillaries. Now, since we cannot measure the oxygen, we are using carbon monoxide as a surrogate gas. And why are we using carbon monoxide? Because it is a diffusion limited gas and not perfusion limited. So the partial pressure of carbon monoxide in your capillary plasma is effectively zero because it is not usually present in the capillaries. So the sole property of carbon monoxide that we are using over here is a diffusion. So we understand how is the integrity of the alveolar membrane working. Again, another property that this gas has, it has high affinity for hemoglobin. It is 210 to 250 times higher than that of oxygen. So it helps in rapidly diffusing across the membrane and binding to the capillary blood that is available. So another advantage is that you can do this test, in ideal setting. You can do it fast, you can get rapid results, and you can get accurate results if you're using carbon monoxide. Hence, we use carbon monoxide. A small amount of this inspired gas produces measurable changes in your concentration of inspired versus expired gas. So how do we calculate DLCO? DLCO is calculated by using the Krog equation, where your numerator is the volume of carbon monoxide which is transferred per minute. It is divided by the partial pressure of carbon monoxide present in the alveolus minus that of the present in the capillaries. Since capillaries effectively it is zero, so the denominator practically becomes the one which is present in the alveoli, that is the inspired gas that we give through the system, which measures the DLCO, right? So moving ahead as to the different terminologies that we'll be using throughout this presentation so that we are all in sync with what is happening around. So DLCO is the diffusing capacity of the lungs for carbon monoxide. VA is the alveolar volume that can be considered the number of contributing alveolar units. So how many alveolar units are actually helping in diffusing this carbon monoxide across the lungs? KCO is the carbon monoxide transfer coefficient, which is written as DLC upon VA. So this VA and KCO will come to discuss it in subsequent slides. And the first few slides all we'll be discussing is DLCO. How do we measure it? What are the normal values? How do we understand? How do we interpret DLCO? And this KCO and the permeability factor, which is the rate constant for alveolar capillary carbon monoxide transfer, we'll be discussing later. So let's first just focus on what is DLCO. Right. So there are various techniques for estimating DLCO. You have the steady state method, the rebreathing method, or the single breath method. The single breath method is the one which is most commonly used. So let us understand how this DLCO is measured using the single breath method. You have various steps that you have to go through. The first one is calibrating and preparing the equipment. So your equipment has to be really appropriate and ready to do the test. You review your spirometry data and adjust the expired volume criteria if appropriate. Then you have to enter the recent hemoglobin and adjust for carboxyhemoglobin if available, if you have that value, but at least adjust for hemoglobin, because as I told you, carbon monoxide has got high affinity for hemoglobin. So if the hemoglobin is low, your value will decrease. If the hemoglobin is high, the value will raise. So important is that you enter the recent hemoglobin value. And if you're doing multiple maneuvers, again, important is that you wait for a period of 4 minutes between maneuvers so that the gas has been expired out and you're doing a new test. Otherwise, in between tests, the gas which you have given before will lead to mal results, the results which are not interpretable. So perform until acceptability and repeatability criteria are achieved, or a maximum of 5 maneuvers. So we will understand what are these acceptability criteria, repeatability criteria also in the subsequent slides. Right. So first of all, let us understand how you will perform the test. This is a walk chart where you understand what all you have to do. Very, very simple test. The first thing that you tell your patient is you take few normal tidal breaths. Just do normal tidal breathing. And once the patient is comfortable, you tell them to have a full exhalation to residual volume. After a full exhalation, your mouthpiece is connected to the test gas. They have to do a rapid inhalation to total lung capacity in less than 4 seconds. So this is a very important step. First is full exhalation and then full inhalation to total lung capacity in less than 4 seconds. This is the time when they are inhaling your test gas. And after the test gas is inhaled, and this much duration of time, the breath holding is the next step, a 10 second of breath hold. Then you do a rapid and complete exhalation to your residual volume. Again, this has to be a rapid and complete inhalation. So when you are going to examine the exhaled gas, the first few seconds are not collected. They are exhaled. They are not taken in calculation for dead space. And the rest of the gas calculation is taken as the calculation for your DLCO. Right. So over here, this is a graphical representation of how you will perform the test. So the first over here that you can see is normal tidal breaths. You tell the patient to take a few normal tidal breaths. There are exhalation completely to residual volume, followed by a rapid inspiration up to total lung capacity in less than 4 seconds. Over here, they are inspiring your test gas, and then a breath holding is happening for 10 seconds, and then a rapid exhalation is happening back to your residual volume. The first few seconds are not taken into calculation for dead space, and the rest one is taken for your calculation. So step 1, step 2, step 3, where you're connecting to the mouthpiece, there is a rapid inhalation to less than 4 seconds, breath holding, and then your expiration. Right? This is again a similar graphical representation with the seconds, with the timeline as well. So all of these steps are important for the test to be acceptable. So when you're performing the test, you have to see that all these criteria are met. That inspiration has happened to the residual volume, and then rapid inspiration has happened up to the total lung capacity. This should be at least 90% of the largest vital capacity. It should occur in less than 4 seconds, or at least 85% in the same test session with an alveolar volume within 200 ml or 5% of the largest alveolar volume from other acceptable maneuvers. So if you're performing 2 or 3 maneuvers, see to it that your vital capacity is at least within this 85% and alveolar volume is within 200 ml of your other acceptable maneuvers. And then the breath holding has to be between 8 to 12 seconds. Exhalation again rapid with total exhalation of less than 4 seconds. So average of 2 or more acceptable tests we can be reported, and duplicate determination should be within 2 ml per minute. So if you're performing more number of tests, see to it that even those tests repeatability criteria is maintained like this. So depending upon the various criteria that we saw in performing the DLCO, the various things are charted into grading categories from A to F. So if the first thing is your vital capacity, how much inspiration has happened, how much is the breath holding, and how much is the sample collection time, that is your exhalation to less than 4 seconds. So when all of the three criteria are met properly, the grading is given A, that test is acceptable. Grading is given B when this is more than 85%, not 90%. So A and B are really acceptable tests, but anything below B, that is C, D, F, where either your inspiratory capacity is less, or your sample collection time is less, or the breath holding is less, they or more rather also are not acceptable test, right? So for example, if you see over here, this is a standard DLCO report. This is how you will see it when you get the report. Patient has taken a few tidal volumes, taken a exhalation, and then an inspiration, breath holding, and exhalation. What over here we can see that the inspiration has not happened up to the total lung capacity. It is only up to 48%. So it is not actually an acceptable test. But on the other hand, if you see this test, okay, there has been a rapid inspiration. The tidal volume, that the inspiratory capacity that we want is achieved. The breath holding has happened properly up to 10 seconds, rather more than that, and but less than 12 seconds. There is a rapid inhalation also happening to less than 4 seconds. So this is a definitely acceptable test. That's why it's given a green A. So see to it, the first and most important thing, that it is a acceptable test. Again over here, if somebody can, understand what is happening, what is the fault over here? The rapid exhalation has not happened properly, okay? And the breath holding time is also not adequately happened over here, if you can see. So this is the ATS criteria and the list, okay? So you have to tick mark all of them, and then you see with what grading it fits into A, B, C, D, or F. And unless it is into A or B, you will not accept the test. So this is the first important part to cover. That is, how is your test performed. Next comes are the values. So once your test is performed, we read the values. A normal DLCO is between 76 to 140%. We categorize it as normal. Mild reduction 61 to 75%, moderate 41 to 60%, and less than 40% is severe reduction. Now, because these kind of values had lot of variations depending upon the age, sex, ethnicity, ATS ERS has introduced Z-score criteria for even DLCO, like it's been introduced for your spirometries. So Z-score of minus 1.65 to minus 2.5 is taken as mild, minus 2.5 to minus 4 is taken as moderate, and less than minus 4.1 is taken as severe. Now let us move on to understanding what did I mean by alveolar volume and KCO. So now many times it may happen that the alveoli is not functioning, you have got less alveoli and hence your DLC is low. Sometimes it may happen that your alveolar volume is normal, but only your membrane, the diffusion of the gas is abnormal. So you have to understand what is the problem with your patient, and hence two more factors have been introduced. One is the most important is the alveolar volume, and then KCO is DLCO by VA. So DLCO upon the diffusion capacity per unit of lung volume. How do we interpret this? Let us try to understand that. So suppose there is a patient with a restrictive lung disease like your IPF. Over here, the alveolar structure is destroyed, your alveolar membrane is destroyed. So both your VA is reduced, your DLC is reduced, so hence your KCO is decreased severely, leading to a reduced DLCO. So your DLCO is decreased, your VA is decreased, so your KCO is decreased over here. On the other hand, if a patient has got an extra pulmonary restrictive defect, okay, like your kyphoscoliosis, a phrenic nerve palsy, a myasthenia gravis, the lung parenchyma is pristine, but the chest wall muscles are not expanding it. So what is happening? Your DLCO is only slightly decreased, but your VA is decreased, and hence your KCO is normal or elevated. I'll again go back to the formula of KCO over here. So it is DLCO by VA. The VA is intact. DLCO is mildly decreased over here. So your KCO remains normal or elevated because your VA is decreased in this case, and hence KCO becomes elevated because DLCO is mildly decreased. I hope we can get it through the formula. If any doubts, we can discuss it in the further question answer session about this. So when looking at a DLCO report, you have to classify based on whether there is an increased DLCO or decreased DLCO. In what conditions we will see decreased DLCO. So as I told you, ILD, one of the most common conditions in which you will not only use for diagnosis but also prognosis of ILD, the DLCO will be used. Why does DLCO decrease? Because there is increased membrane thickness because of fibrosis. So your diffusion is severely impaired. It is a very classical finding of decreased DLCO seen in your cases of ILD. Then another common condition in which your PFT may be normal, but your DLCO will be decreased is your pulmonary vascular disease. There is decrease in the pulmonary capillary volume. If the blood volume is decreased, the carbon monoxide has no blood to bind, and hence your DLCO is decreased. In cases of emphysema, so you see a PFT which is showing you obstruction, or you see your body box which is showing your high lung volumes, high residual volumes, but your DLCO is decreased. That can happen in emphysema because of destruction of alveolar walls. So the surface area is decreased and hence DLCO is decreased. Another condition which I already told you is anemia. So if the hemoglobin is low, your carbon monoxide is not able to bind, and hence always have a corrected value of DLCO with hemoglobin. So enter the hemoglobin value before you perform the test. Are there conditions in which DLCO can increase? There are certain conditions in which this can also happen. For example, alveolar hemorrhage. There is too much blood in the system. If there is too much blood, carbon monoxide avidly binds to this free hemoglobin. Hence, what happens? Your DLCO increases. This happens in cases of pulmonary Goodpasture syndrome or GPA Wegener's whenever you have a diffuse alveolar hemorrhage in this patient. So if an ILD patient has suddenly increased DLCO, it will suggest that the patient may have diffuse alveolar hemorrhage. Conditions of polycythemia, high hemoglobin binding sites, high DLCO. Conditions of left to right shunts, again, extra blood flow, extra DLCO. Asthma. In many cases of asthma, there is increased blood flow in the lungs, and that causes high DLCO. And in cases of severe obesity or exercise, again, increased cardiac output, increased pulmonary capillary, increased blood flow causes increased DLCO. And so we understood causes of decreased DLCO, increased DLCO. Important, as I told you, there are certain mandatory clinical corrections that you have to do before interpreting these values. First of all, hemoglobin. Always try to enter and correct it for hemoglobin. In some cases, carboxyhemoglobin may interfere with the values of DLCO. So if there is already carboxyhemoglobin present, your carbon monoxide will not be able to bind, and hence you will get decreased DLCO in such cases. So when can you get carboxyhemoglobin? Very commonly seen in active smokers. Okay. So you should instruct your patients to avoid smoking at least 12 hours prior to the test. Another condition in which can hamper your DLCO reading is your alveolar PO. So suppose if it is performed at a higher altitude where your alveolar oxygen is already low. So because oxygen is already low, carbon monoxide has got more sites to bind. So it will lead to falsely elevated DLCO. Similar condition can happen of falsely low DLCO when there is an oxygen supplementation going on. So if your patient is on oxygen, and on oxygen if you do DLCO, there are decreased binding sites for DLCO. So again, falsely decreased DLCO. In these cases, if possible, discontinue oxygen for 5 to 10 minutes if it is safe before the test. Right. So majorly I have covered what is DLCO, how do you measure it, what are the normal values, when will you find increased DLCO or decreased DLCO, how do we interpret it in terms of alveolar volumes, what mandatory corrections we need to do. I will just finish my talk with a few interesting case snippets now. So you will see very commonly that you're following up a case of ILD, CTD ILD, it may be a case of scleroderma, systemic sclerosis. You're seeing that your patient is having barely maintained DLCO, and suddenly on the follow-up, you see that though the FVC is normal, a DLCO has dropped. It is a major red flag for development of pulmonary artery hypertension, and this you can pick up early if you're doing DLCO simultaneously with your PFD and regular follow-ups for this patient. Another important case where DLCO can help you is a pre-operative risk assessment. So we calculate FEV1 in a pre-operative risk assessment, the post-operative predicted FEV1. Again, your post-operative predicted DLCO of less than 30 also indicates a high risk for peri-operative mortality and major cardiopulmonary complication. So it is important to calculate DLCO for these patients also. And the last one. So you do it for your ILD patients in regular diagnosis, monitoring, COPD. In cases of asthma, you may do it at the first instance when they're coming to you. In some cases, again, you will do it for regular monitoring, such as drug-induced toxicity monitoring. So there are certain drugs which can cause interstitial pneumonitis, like icodron, bleomycin, methotrexate. In these cases, when you're regularly monitoring these patients, a drop of even 15 to 20 from baseline warrants an immediate drug cessation because of impending drug-induced interstitial pneumonitis. So take-home messages, clinical pulse over here, as I told you. If there is a low DLCO but your PFT, your spirometry shows obstruction, think of emphysema or COPD. If there is a low DLCO and your spirometry shows restriction, think of ILD or interstitial fibrosis. You have isolated low DLCO, first think of pulmonary vascular problem like pulmonary hypertension, pulmonary embolism, anemia. There can also be early ILD or early emphysema. High DLCO, we discuss asthma, obesity, polycythemia, pulmonary hemorrhage. And this again, the last slide showing your algorithm as to how to go about DLCO. So if your DLCO is high, we understood the causes, increased blood flow. If your DLCO is low, but your alveolar volume is normal, we know that there is either a problem with your pulmonary vascular abnormality, your emphysema with preserved lung volume, or anemia. But suppose if your DLCO is low, your alveolar volume is also low, then you see your KCO. If your KCO is high, there is an issue with your neuromuscular dysfunction or loss of localized lung volume. But if your KCO is also low, what we're dealing with here is ILD or emphysema. So these two charts will be most helpful to understand this one and this one to interpret your DLCO readings at a glance. Thank you very much. If any questions, then we will discuss it in the question answer sessions. Thank you very much for a patient listening, and thank you ICS for giving this opportunity. Thank you.
Thank you, Dr. Sumita ma'am, for an excellent overview on DLCO. And I think DLCO is something which we all use routinely, but many a times we forget to interpret it properly. So it's a very, very valuable tool, and understanding it makes a lot of sense. With this, we move on to the next talk by Dr. Nitesh Gupta. Can we have the introduction slide of Dr. Nitesh Gupta? So I think Dr. Nitesh doesn't require much of introduction. You can see him in most of the web meets, academic platforms. And he was my senior and was a colleague at Safdarjung, and always a go-to person for any of the help. And currently he is an associate professor in the Department of Pulmonary Medicine and Critical Care at Safdarjung Hospital, New Delhi. Extremely passionate about his research activities, and contributes to a lot for our scientific publications from India. And today we have him with us to deliver a talk on body box, the basics to advanced, a topic which requires a lot of attention because we are seeing many centers adopting a body box, but how many of us are interpreting it in the correct way is still a question to answer. Over to you, Dr. Nitesh Gupta, for your talk.
So we begin with a case where you have a common scenario of a 58-year-old ex-smoker who comes to you with a complaint of dyspnea on one flight of stairs. You get a very good spirometry done, which is acceptable, and you find a ratio of about 0.72 and FE1 of 82%. So in some group it will be labeled as essentially normal, some would say no, there is some degree of obstruction, and radiology was done which shows mild hyperinflation. So when the spirometry is not clearly giving us what the physiology or in the patient is, which is causing his symptoms, this is where the role of advanced lung volumes come, where you have to measure lung volumes to at least understand what is going inside the lung. Unlike cardiology, where they can just do angiography, see inside the vessels how they are behaving, how much plaque is there, what is their diameter, is it critical, they can open it. We cannot enter inside the lungs to measure their volume. That is why we have devices which work outside, where they reciprocate what is happening inside the lung. So what spirometry tells you is about airflow in the form of FEV1. It tells you obstruction ratio, and it gives an approximate amount of vital capacity. What spirometry misses is how much is the actual gas in the body system. Is my gas trapped inside? Am I overinflating my lungs? Do I have lungs which are not working, that is non-ventilated gas? What lung volumes add, or what the body box add, is FRC. It gives you an FRC by the all thoracic gases. It gives you RV, TLC in different terms. It gives you resistance and conductance, and it gives you an idea about non-communicating spaces. So this is where body box adds. Now coming, why is there a need to measure lung volumes? We can just do a spirometry and just say, okay, you have obstruction or you don't have obstruction. The problem is where we need to look for restriction in the patient. So lung volumes are required for confirmation of restrictive lung diseases. It needs to differentiate between hyperinflation versus air trapping. As the slide said, move forward, we will be able to much more clear why actually we want to differentiate between both. We want to know which part of lung is not working despite being there, and definite importance in a pre-operative evaluation of a patient, either for a thoracic surgery or for a non-thoracic surgery or for a transplantation. So this is where lung volumes measure. Now how can we measure lung volumes? Unfortunately, we do not have a catheter which can go inside the lung and give us a value. We have to rely on ancillary measures. So one is radiology, where a CT volumetry scan can give you the amount of lungs which is there in the air. The other is physiology wise, you measure the lung volume in the form of FRC. Once you have an FRC, you can calculate all other lung volumes and capacities. So FRC is measured by three methods: by the helium washout, by the nitrogen washout, and by the body plethysmograph. Of all the three methods, the gold standard till date remains the FRC pleth via a body box, and not without a body box as by one of the manufacturers. So if you have to measure a gold standard for a lung volume, you need to have a body box. So anybody who is planning to start an evaluation of ILD, who is beginning the practice, and he has to buy a single instrument where he is assured that his patient will be getting all the care, the body box is the thing which is to be done. What is the difference? Why do we need a FRC helium versus a FRC via body box or a thoracic gas volume? Some people also call it as thoracic volume of gas. So TGV and VTG are the two terms which are interchangeable. So if you see, if you do not have any obstruction, FRC by dilution is 2 liters, and FRC by pleth is also same. But in case you have an obstruction in the airways, now this part is no longer participating in the, when you use the FRC by dilution in the helium gas, because the gas is not entering this region, so it will underestimate your FRCs. Whereas when you do a body box, because it measures the amount of gas in the system, it will give you a correct value. So when we talk about body box, if you even when you are a postgraduate and you start reading about body box, you are taken back at least 7 or 8 years back in your studies to the physics, where you have to again remember all the formulas and how the machines are working, and so it becomes more complicated and you end up not reading the topic or not understanding what body box can do. So the over next 15 odd minutes, my job is just to simplify that these are no terms which cannot be understood. So we'll take them one by one. We have to see few laws, few principles, and the things will be much clear. So first thing in this is Boyle's law. Boyle's law just described volume and pressure graph at a constant temperature. So if you see here, your temperature remains constant. As your pressure increases towards right, your volume falls. So in a in a closed chamber where you have pressure and volume at a fixed temperature, they vary inversely. So when you will increase the pressure, your volume will decrease. When you will decrease the pressure, your volume will increase for the same mass and the same temperature. That remains the same. So we have to find a mechanism where we can keep the constant temperature and a constant mass in a chamber so that volume and pressure can follow the Boyle's law. Next comes the Pascal principles. So Pascal principle very simply say in this diagram, at any point of time, there will be the same pressure at whatever distance you measure. So hose pipe for firefighters, a classic example. If you measure the pressure here, if you measure the pressure here, or if you measure the pressure at the mouth where the water is leaking out, these all remains the same. So that is a Pascal's principle and the Boyle's principle. Now combining both, that is where we use the mechanism. We measure the mouth pressure following the Pascal's principle, that whatever is the mouth pressure is the alveolar pressure following P1, P2, P3 theory. So because we cannot put catheters inside the alveoli and measure their pressure, we have because the physics laws allows us to for that time of measurement. So anything inside the alveolus measured at the mouth is same. So that is why we get the alveolar pressures in the body box. So it is a sealed box. Sealed means no air enters inside, no air exits inside. Whatever volume is there, it is fixed. It is a sealant door from where nothing should come out. So it is a sealed box which measures all thoracic gas. It follows the Boyle's law, that is pressure 1 volume 1 is equal to pressure 2 volume 2 at a constant temperature. And it follows the Pascal's law. Wherever you apply the pressure, it is felt equally throughout. So mouth pressure is equal to alveolar pressure when there is no flow. This is why we measure the pressures at the mouth and not inside the lung. Right? So if your Pascal fails, that is if your tongue comes inside the mouthpiece, then the test is not valid at all. These results are invalid. We will see in further diagrams. So the physics simplified form, you just see the Boyle's law, just remember the Pascal's law, that these two are used, and that is why we have a PV relation where changes in the lung measures the changes in the box, and that is what we calculate. So whatever change is there in the box, we just take it that the same is happening in the lung, and whatever the pressures at the mouth, we take it these are the alveolar pressures. And to simplify everything, now the signals are digitally and displayed on the screen. Now there are, when we do the maneuver, there are three different maneuvers. The term we need to understand. One is shutter opens, that is the mouth and the machine which is connected. It has a shutter which is opened, which is closed, and the maneuver which we do. When you have a shutter open, you need to pant at a frequency of 1.5 to 2 Hz, that is about 90 to 120 per minute. If you have a shutter closed, you need to pant at a lower rate, that is 30 to 60. We will see in the further diagram. The most important thing is the VTG which we are measuring, or thoracic gas volume which we are measuring, and the airway resistance which we will measure in the next few slides which we will see. They are at different frequencies, so they should be measured differently, not at the same time. So this is how the things begin. First you have an equipment setup. So equipment setup is, you ask the patient to make him understand what you are going to do, how he should breathe, show them with a diagram that this is how it is going to go. You calibrate your machine pre-hand and not when patient is inside. And the room where the machine is there should not have generators below it or generators above it where vibration disturbances are there, because then this dwells up with the pressure changes in the box. So first, once you have counseled the patient, you make him sit inside and you close the cabin door. Once you close the cabin door, you have to wait for 30 seconds to 2 minutes for pressure equalization to be there. Otherwise your test will fail, or your patient will not be relaxed enough, he'll feel claustrophobic and come out. It has now been done away with because the boxes are transparent throughout, so patient can see outside what is there. There is a mic inside, patient can communicate with you very easily. Your communication also goes inside through the same system. Then we ask the patient to do a quiet tidal breathing, as we can see, till this stable expiratory levels are achieved. If your tidal breathing say goes like this, this, this and this upwards, that means there is equilibrium has not been achieved, there is a thermal shift, and you do not need to do the test. You need to again ask the patient to breathe at a constant level so that this baseline can be achieved. Once the stable expiratory is achieved, you close the shutter, ask the patient to take panting breaths for 2 to 3 seconds, and there is a pressure limit on the graph where it shows it should be within plus minus 10. If it is below plus minus 10, then that panting is not good enough. You ask the patient to pant more. Then once the shutter is opened, you ask the patient to take a normal breath, go till the inspiratory capacity, completely expire till the expiratory reserve volume is achieved, and then resume the normal breaths. Earlier this was like once you have opened the shutter here, you could go below expire completely and inspire then, but this has been done away with the 23 guidelines for body plethysmography or the lung volumes, where they say you go for inspiration first and then expiration. The physiological rationale is once you have been asked to stop your breathing, the body's response is to inhale a deep breath rather to exhale a breath. That is why it has been changed to inhale rather than to exhale. Perform inspiratory maneuver followed by EVC. Operator verification. We'll see the graph. How do we verify? Verify thoracic gas volume and FRC pleth. And the important is do not combine airway resistance and lung volume testing. If you are testing lung volume, first test the lung volume completely, then take up for the airway resisting. If you are not testing for lung volume, then you can take the airway resistance at the beginning. So this is just a short video on how it goes. So this is how the patient management portal looks like, where you enter the data, you connect to the device. When sensor is calibrating, it says do not do the sensor. Then it asks you to close the cabin door. You close the cabin door, because if you keep it open, it's not a body box anymore. So once you have closed the body box, machine gives you the signal, yes, body box has been closed. You wait for 30 seconds to 1 minute, and then you ask the patient to breathe at a tidal rate. Here if you see, the patient is breathing. You are getting the airway resistance graph, but your focus is currently the tangent graph, that is the flow and the pressure graph. So we can see as patient is breathing, we are getting different types of loops which are in a constant pattern, and your tangent is getting developed. So once the stable state tidal breathing is achieved, then you close the shutter. We'll see here, we'll be closing the shutter. So shutter has been closed, patient has been asked to pant. Say he expires, he takes the inspirate, he'll take few tidal breaths, then he'll take the maximum inspiratory capacity and expire. And you will keep getting the PFT loop here, you will keep getting the pressure volume graph here, you will keep getting the resistance graph, you will keep getting the tangent, which you have to calculate to see for obstructive or restrictive. So here we can see patient is now doing a complete inspiratory maneuver, and now you will do a completely expiratory maneuver. So when the software goes like, there is a thoracic gas volume loop morphology, where on the x-axis there is a box pressure, also known as volume. So as you move from RV on this end to TLC at this end, and as pressure falls, so below is inspiration and above is expiration, and this is how the tangent keeps building up for every time you take a breath. Now when we have to see for obstruction, we can see the tangent is more towards the x-axis rather than y-axis, that it is lying, it is in a sleeping position. This is suggestive of obstruction because the lung is very compliant. When it remains more towards vertical axis, that means the lungs are very stiff, it is suggestive of restriction. Then, but if you pant before the shutter closes, then your volumes get disturbed and you get lot of different thoracic gas volumes. This means the maneuver has not been done appropriately. So this is how the three things look like. So you have a normal, obstructive, restrictive. So it is more towards the x-axis lying, it's an obstruction. If it more towards vertical and y, it is a restriction. So this is how the normal box pressure versus volume looks like. If they keep moving and they do not follow a single drifting line, that means there is a thermal drift, that is there is a change in temperature. and that is causing a thermal drift, we need to stop the test and get the temperature sensors on and get it calibrated. So normally this is how the hysteresis look like. It is very close to each other because expiration is passive, so it does not follow the path of inspiration. But if excessive efforts are used, the distance increases. So in the end, this is what we get overall. So we get RV, we get FRC, we get TLC. So normally the total lung capacity, the FRC and the RV have a specific ratio. If your TLC is reduced, we call it restrictive straight away. If your TLC is normal, as a normal healthy, but your RV is increased, air trapping. If your TLC increased totally, but your RV and FRC remains in the same ratio, we call it hyperinflation. If your TLC falls, but your RV and FRC ratios remain nearly normal, we call it neuromuscular weakness. If it is restrictive, all three lung volumes fall, the TLC falls, the FRC falls and the RV falls. So this is how we define the patterns of lung volumes which we obtain from the testing. Now just like in DLCO, we have seen there is an acceptability criteria and there is grading system. So acceptability criteria is divided into two parts. One is acceptable, that is a gold standard. Yes, everything is right. Second is because patient is putting lot of efforts, we are getting the graphs, we are getting some information, we must use it. So there is a criteria for usability. And then there is a criteria which neither you accept it nor you use it, that is reject. So between accept and reject, there is one more term which is usable. And how do you grade? Just like DLCO, you grade it into A, B, C, D, E, F, U, where A and B are the best ones which should be there. For quality control, there is a motor inside the body box machine which has a ml of 50 ml volume, and it calibrates into the machine at a constant temperature. Then there should be two normal control subjects whose test should be done on the machine. The GLI references should be used for lung volumes. For raw and specific conductance, the GLI is still not been established. So when we call it acceptable, when you have more than 3 tidal breaths, FRC becomes stable, variation is less than 15%, no thermal drift, loops are closed, pant rates are norm within range, pressure within calibrated range, FRC values agree within 5% of the 3 values, and report mean of acceptable values. So we have acceptable, usable and unacceptable. So when you have air trapping versus hyperinflation, since both have elevated RV but only one has elevated TLC. So when there is air trapping, your RV by TLC is more than 35% of upper limit of normal. TLC may be normal or nearly normal. RV rises at the expense of VC. Seen in asthma and early COPD, when your VC is reduced but TLC is normal. Hyperinflation on the other hand is when TLC is more than upper limit of normal. RV by TLC, because TLC increases, RV by TLC is also elevated. Lung is stretched beyond the normal. It is seen in emphysema, and the difference between both of them is when you have increased TLC, you look at the lung volume reduction strategies. When you have air trapping, you look at the fact that how do I open up the airways so that the trapped air gets exhaled. So there is a therapeutic difference between air trapping and hyperinflation. Next comes the airway resistance. Usually if we see as we move from upper airways to the lower airways, the branching increases, the number increases of the airways. So practically we believe that resistance should ideally increase. But the resistance, as we have seen, gradually falls as we move to the several airways. That is why as we move from top to bottom, that is as we increase the lung volume, the pressure resistance falls. But it is not in a linear, it's in a curvilinear pattern. So the normal resistance values is less than 3, conductance is more than 0.15. If it is more than 3, it is high resistance. If it is less than 0.15, the conductance is low. These are abnormal. So why we use a specific conductance and not the resistance? Because the resistance changes with lung volume, as we have seen in the previous slide. The resistance changes with lung volume. So we need to neutralize it and we take it as a conductance. So if your conductance is affected, it catches very early a small airway disease. So may be abnormal even before FEV1 changes. And in cases where you have FE1 is reduced, FVC is reduced, but your ratio is normal, your TLC is normal, but resistance is increased or conductance is decreased, you find it as airway hyperreactivity or obesity and not as restriction. So this is where, when you have a non-specific pattern, your calculation of resistance and conductance comes into the play. So these are how this is how normal conductance resistance graph looks like. If you have inspiratory flow and expiratory flow, if your rate is too high, then it comes like this. If your volume is too large, the shape comes like this. If you have a thermal shift, it goes like this. If you have a high expiratory rate, it bends at the end. If you have a high expiratory resistance, it bends in the your expiratory slope. If you have a fix, there are bends at both the ends. And if you have asthma, the work increases. So just by looking it, just like with ECG, you just study the pattern. So just by looking at the pattern, you will understand what my raw and these are there. Now how can the errors be there? The errors can be because of the equipment. The error can be because the testing personnel is busy in other work and not following the instruction to the patient. And third is the patient who is not able to understand the instructions clearly. So when there is a body box and it is leaking, the fixing the box with the tape is not the answer. Just like you will not fix your car or an aeroplane with the tape, you will want it to be a replacement. So when your equipment leaks from any place, please replace the entire body box. It is not a tire puncture where you can keep repair and keep measuring the volumes. Then the personnel needs to be trained and retrained on calibration, on the patterns which we see, where the errors are creeping, and the patient must understand all the reactions. So when I see a high TLC, a high RV and a high RV by TLC, it is a hyperinflation plus air trapping. When I see just RV by TLC is increasing and TLC is normal, we see it is air trapping without hyperinflation. TLC falls but ratio is normal or increase, it is restriction. TLC falls, ratio falls, but RV by TLC increases. So if TLC falls, it is restrictive. FE1 FVC falls, it is obstructive. So it's a mixed effect. FE1 falls, FVC falls, ratio remains normal, TLC remains normal, but airway resistance increases. So this is not restriction, but this may be a bronchial hyperreactivity or even obesity. When spirometry is normal but symptoms persist, you may do an FRC pleth versus FRC dilution, that is doing FRC by body box as well as by helium or nitrogen. If the ratio remains more than 1, that means there is a bulla, which is a non-communicating gas and needs to be removed. Thank you for your kind attention.
Thank you, Dr. Nitesh, sir, for an excellent talk. But looking at this, the PFT seems to be more complicated than before. Understanding the body box, I think it requires a lot of practice before we start understanding it completely. And so to get away from all these doubts, we have a panel discussion today on the pertaining topics related to body box and DLCO. For that, we have a set of eminent panelists from across the country. We have Dr. Mansi Gupta. Can we have the slide of Dr. Mansi Gupta? Dr. Mansi Gupta has done her DM in pulmonary and critical care from Safdarjung, New Delhi, and currently she is a additional professor at SDPGI Lucknow, and she has a lot of publications, and her primary interest is in academics, especially in conducting OSCE stations and training young pulmonologists. Along with Dr. Mansi Gupta, we have our next panelist, Dr. Girish Agrawal, a good friend of mine and a senior. And he is currently practicing as a consultant in pulmonary and critical care and sleep medicine at Ramakrishna Hospital in Raipur. And his key areas of interest include interventional pulmonology and critical care. And along with this, we have our next panelist, Dr. Srikanth Juvva from Hyderabad. He is currently working as a consultant interventional pulmonologist at Apollo Hyderabad Financial District. And we had one more panelist, Dr. Samir, but because of some emergency, he couldn't join us. So we'll go ahead directly to the panel discussion. And I'll be moderating this session to
move to the first talk, first question. This is to Dr. Mansi. So, routinely at a clinical practice, we use the spirometry, but when do you really think a body box is needed for further evaluation beyond your spirometry?
Thank you, Vishwesh, for the question, and thank you, ICS, for having this wonderful webinar today. So for this question, we all are routinely doing spirometry. It's the most commonly performed test, but we should understand that spirometry is a dynamic lung assessment, pulmonary function assessment, whereas lung volumes are static lung volume assessment. So spirometry, when we do, it will tell you about the airflow which is happening in the dynamic state, whereas how lung reserves are will be given by your lung volume assessment. So whenever your patient is suspecting some clinical problem and your spirometry alone is not able to answer the physiological defect, then probably you should be proceeding to do a lung volume assessment. And most commonly, there are some discrepancies in assessment of spirometry, wherein your FEV1 and FEC values are normal or your the ratios are preserved, but you need to assess the lung volumes to be able to decipher the hidden disorders. Most commonly, as Nitesh has already pointed out, that you may be having problems of air trapping and hyperinflation. So those can be the things. And also, we'll be coming to that later that, for any, as we classify disorders into obstruction and restriction, for true restriction to be identified, lung volumes have to be done. So these are the two most important things that lung volumes have to be done.
Yeah, excellent points, Dr. Mansi ma'am. And with this, we come to Dr. Girish. As Dr. Mansi ma'am said, like you cannot assess a true restriction with FEC alone. So, what is your take on this, Dr. Girish? Like, is a low FEC equivalent to a restrictive lung disease, or you would want to evaluate further?
Thank you, Vishwesh, and thank you, ICS. Yes, as Mansi rightly pointed out, we need volume assessment to actually classify restriction as highlighted by Nitesh also in his talk. Right. So to say actually is a restrictive lung disease, we need total lung capacity. But the traditional teaching or the basic teaching is whenever we look at the FEV1, we look for obstruction, and whenever we look at the FEC, we look for restriction. But however, there are many cases or there are many clinical scenarios in which FVC may be reduced, but there is no restrictive lung disease. As the FVC stands, it is a forced vital capacity. So the first thing which comes is a patient effort. He has to forcefully exhale his lungs out. He has to forcefully exhale the volume. So if there is a poor effort from the patient, if there is a cough in between the procedure, if there is early glottic closure, or if there is any diaphragmatic or neuromuscular weakness, he may not be able to exhale fully. Though the lung parenchyma remains the normal, but the FVC will be low. Same with it can happen in the obesity patients where there is a cephalate movement of the diaphragm. Right. Same can happen even in the obstructive airway disease where we see there is a what we call a pseudo normalizations of the FE1 FVC ratio. There is a reduction in the FE1, there is a reduction in the FVC, but the ratio remains the normal. Right. So the reason why FVC is reduced in obstructive airway disease, particularly in severe asthma or the COPDs, as patients start exhaling, the intrathoracic pressure builds up and it tends to collapses the airways. So the closing capacity starts moving towards the FRC and the equal pressure point moves moving towards the alveoli. As a result, the airway collapses very early as compared to the normal patient. As a result, patient cannot exhale fully. So FVC does not mean it is a reduced FVC does not mean it is a restriction.
Yeah, excellent point, sir. And now we came to know that FEC is low FEC doesn't equivalent to a restrictive lung disease. You need further evaluation. But to Dr. Srikanth, is there a way we can differentiate the two restriction from pseudo restriction due to air trapping, which you see in patients like emphysema or advanced COPD?
Yes, sir. Thank you, ICS, for having me with you in this wonderful webinar. So the answer to the question is, whenever we see low FEC, so it is just a screening clue that we already know, and it is beyond doubt that is proven from the lecture that it should be the TLC should be low, that is below the lower limit of the normal, or it should be less than 5th percentile to confirm as the restriction. Whereas in pseudo restriction, your FVC will be low, but your TLC is normal or increased. Or in other words, it can be RV by TLC also can be increased. So when FVC, low FVC is referred to to me, what I'll think is it just a normal pseudo restriction, or is it just a small lung unable to empty because of a severe air trapping? These is 2 points I'll try to see to differentiate between the true restriction and the pseudo restriction.
Yeah. So to Dr. Sumita, so we understood from all the panelists here, you need a TLC to be the defining pattern for confirming the restriction. Do you believe in that, or do you feel is there any other way you can assess the restrictive capacity of the lung in a definitive way?
Yeah, I would say definitely total lung capacity is the gold standard for confirming a restrictive ventilated effect. Because fundamentally what is happening in restriction is a reduction in your total lung volume. Your FVC can be decreased. There can be normal or high FEV1 by FVC ratio. But this pattern may not suggest restriction. As we said, low FVC can be because of severe obstruction with air trapping, poor effort, or neuromuscular weakness. Thus, your reduced FVC will not define restriction. Only TLC will directly measure whether lung volume is actually reduced or not.
Yeah. So to Dr. Nitesh, we heard from Dr. Srikanth about air trapping causing a pseudo-restrictive pattern. So if I want to find out one parameter which best reflects the air trapping, what would you choose? Would you choose a residual volume, or a RV by TLC, or an FRC by TLC, or an inspiratory capacity by TLC?
Right. So as we have seen, RV by TLC ratio is the most widely validated and clinically standardized parameter for air trapping. It directly tells you what amount of air of the TLC cannot be exhaled, and upper limit of more than 35% established across the population.
Yeah.
The other ratio which is being studied and is there is inspiratory capacity by TLC ratio. It has shown when it is less than 0.25, it shows dyspnea, predicts mortality and exercise intolerance better than FEV1 alone. In your daily practice, RV by TLC used to diagnose and grade air trapping, and if you have a case of COPDs and you are going to follow up them for a longer time, then you can use IC by TLC to explain their symptoms and response to the therapy.
Yeah, for the audience here, this is a very, very important parameter, your RV by TLC, because most of the clinical trials which revolved around even bronchoscopic managements of these COPD look into the RV by TLC, which is an important component of your air trapping, and anything that reduces the air trapping in COPD can bring about an improvement in your dyspnea scores and even in inspiratory capacity. So to Dr. Mansi again, so can lung volumes explain dyspnea better than FEV1 in COPD, especially in hyperinflated patients?
Definitely, I think Nitesh has already in his talk excellently talked about air trapping and hyperinflation concept. Most importantly, there was a time when FEV1 was a sole prognostic marker apart from the clinical scales like Borg was used a lot, and there were certain indices. But over the time when we started doing lung volumes and the technique has evolved, this inspiratory capacitor to TLC ratio, which will tell you not only about the static condition of the lung in terms of the poor reserve, lung reserve less than 25% the ratio. Apart from that, dynamic hyperinflation would also be highlighted by that ratio because that patient is generally having a very poor reserve. So, in terms of prognostication, if we talk about a treatable trait concept like in terms of air trapping and hyperinflation, so lung volumes are definitely a better marker as compared to FEV1.
Yeah.
So maybe you can do FEV1 as a initial screening, but for classifying clinically a patient and prognostication, volumes are better.
Yeah, so for the take-home message for all the audience here is your body box provides much better values for understanding your lung physiology, especially for differentiating restriction from pseudo-restriction, and even for determining the air trapping, which is very, very important when it comes to management of COPD. So now to Dr. Girish, we know multiple methods of estimating the lung volume, but why does helium dilution always underestimate the lung volume in severe COPD diseases? Is there any particular rationale to it?
I think about the diffusion lung capacity and body box, we combine both of this. Dr. Sumita has already highlighted that by doing single breath method or 2 to 3 breath method, helium dilution technique or use of helium gas for measuring the diffusion lung capacity. It can measure only those gases which communicates with the airway. If there is a bulla, if there is a volume in the lung which is not communicating with the airway, or as in case of obstructive airway disease, because of the different time constant of the alveoli, some of the alveoli may be getting ventilated within a short span of time. Some of the alveoli may be getting ventilated for a longer duration of time. Some may not be communicating at all. So those lung volume, because it is for the fixed time which we do the DLCO 3 second, 4 second. In those time, if those alveoli are not getting ventilated or there is simply no communication, then those volume cannot be measured. And that is why whenever we do total lung capacity with the help of body box, it measures the entire total thoracic gas in the system, not only the communicating one. And that's why there is a difference in the total lung capacity when measured by body plethysmography and then by the helium dilution method. Right. And even this, while we are interpreting with the diffusion lung capacity and body box, if there is a gross difference and rest of the parameters may be mildly deranged, we can see that if the total lung capacity with the body box is more and significantly more than by the helium dilution, there is underlying emphysema or there is severe asthma or there is a bronchiolitis, small airway, which can happen. So only communicating alveoli are measured with the help of helium dilution.
Yeah. So the important point is when you have a bulla or when you have a non-communicating part of a lung, maybe your helium dilution will underestimate your total lung volume, which will play an important role, especially when you want to plan some interventions or even for surgical management. And to Dr. Srikanth, why can body plethysmography overestimate total gas volume in severe airway obstruction, and how can we minimize this error?
As we already seen from Dr. Nitesh's talk, so body box main principle is the basis of the shutter closure, where your mouth pressure reflects the alveolar pressure. But in cases of, in the question you had asked, there is severe obstruction. So the problem here is the pressure changes in the alveoli may not be transmitted instantly to the mouth, which creates a lag of mouth and alveolar pressure lag will be created. So as a result of this lag, your gas volumes will be overestimated instead of underestimation. So how we can overcome this overestimation of lung volumes is by following adequate technique. So the technique already points or acceptability criteria are very well covered by Nitesh sir, with gentle panting and adequate frequency, and there should be proper good mouth seal, and the shutter should be closed close to FRC. That is also very, very important. What happens routinely, the shutter is closed slightly above the FRC. So what happens is there will be overestimation of your thoracic gas volume will be overestimated. So in severe obstruction, in the lung behaves as a multiple slow compartment, like in this scenario, rather than a single lung. So that's why we will overestimate the thoracic gas volume with the help of body box.
Yeah. And to Dr. Sumita, like are airway resistant parameters like RAW and SGAW still clinically relevant in modern pulmonology practice? And I want you to define these terms for the audience here as well.
Yeah, definitely, Vishwesh. So your RAW is the airway resistance and your SGAW is the specific airway conductance. So though they are still clinically relevant, their use is now limited because and selective, okay, in routine pulmonology, because we have got your spirometry, which gives us a lot of values, and we have DLCO. These are very sensitive indicators which detect your airway calibers to detect airflow obstruction earlier than spirometry and your selected situations. But there is a lot of variability, limited standardization. As discussed with Nitesh, there are so many variables, that can happen when you're doing this test. There is lack of added value over spirometry in most patients. So most patients will give you your FEC, FE1, FE1 by FEC, then you have DLCO. But when you want to calculate in cases that these parameters are not helping you, you're still suspecting there is an airway resistance going on, in those cases, these parameters are helpful. So not in everyday clinical practice, but in certain cases where your spirometry is inconclusive, these parameters will really come in value to come to a diagnosis.
Yeah. And to Dr. Nitesh, like you said a lot about body box. So coming to that, do you see in the future there should be a shift away from just a PFT interpretation and utilize these advanced modalities of body box, DLCO, oscillometries, and radiological imaging to comprehensively phenotype a particular patient of a lung disease for effective management, or do you think that most of the science is more of theoretical rather than of a practical utility?
Changes in, as we have seen in recent changes in guideline, the guideline now no longer tells you it is a disease. The guidelines tell you what is the physiology. That is where everything changes. It just gives you what is going inside. Now you have to label it as per the disease based on all your history, investigations, and concomitant methods in which you can do. So practically a single spirometric parameter cannot tell you anything about hyperinflation, trapping, diffusion, muscle airway mechanics, or vascular pathology. When you combine a lot of these things, that is where you are able to pinpoint what is the problem happening. For an example, say you have a patient who has hyperinflated air trapped COPD, but diffusion is preserved and elevated resistance is there. The treatment in that patient would be different than a patient who is a COPD, normal lung volume but a low DLCO. Because the hyperinflated air trapped patient, the treatment would be targeted towards volume reduction, whereas a patient who has COPD, normal lung volumes but low DLCO, so there you may even evaluate for vascular causes or anti-emphysema. So the COPD gene cohort as well as spirometric data cohorts, which are the global cohorts and including patients from India, they said that CT and PFT, when they combine, they predict exacerbation and mortality far better than just by gold spirometric grading. That is why it is now more about precision medicine for every patient rather than blanket treatment for every patient.
Yeah, excellent point. So I think we have to treat the treatable traits. So I think these knowledge of body box will help us in understanding what can be treated. Like if it is a hyperinflation, then probably you have to be aggressive on treating the hyperinflation rather than focusing more on the diffusion. So now we move on to Dr. Mansi. Is DLCO, now we'll take a little bit questions about DLCO, which is of more practical relevance because many of us do have an access to the DLCO. So is DLCO truly a diffusion capacity, or is TLCO, the transfer factor, physiologically more accurate term? So first of all, for the audience, what is DLCO and what is TLCO, and how TLCO plays an important role in comparison to a DLCO?
So, Sumita was telling about all those factors that are important when you're measuring the gas exchange impairment. DLCO basically tells you about gas exchange impairment. So it is not just dependent upon the alveolar-capillary membrane. It also depends on the pulmonary vasculature, the hemoglobin binding, the distribution of ventilation, the alveolar gas volumes that you have. So the whole maneuver will have many components. So when we say a term like diffusion capacity, it just probably implies a very limited terminology in terms of the alveolar-capillary membrane stability or the goodness of it. But when we say the whole concept of a physiologically more precise term like a transfer factor, then probably we are talking about a much more wider range of things which can be covered, including the pulmonary vasculature, including the alveolar capillary membrane stability. So that is why probably the new guidelines are also pushing for this term called transfer factor instead of using DLCO. So technically it is more correct, but since we have been using the term DLCO for a very long time, so probably people are more comfortable using it.
Yeah. And to Dr. Girish, we hear about certain term called KCO. When we interpret this DLCO, it comes as a part of the interpretation. So what does it mean, and how it can help the clinician in routine practice?
Look, first let's separate DLCO and KCO, right? So DLCO is a diffusion lung capacity of whole lung, and KCO is diffusion efficiency of a lung unit, alveolar unit, right? So one represent a very minute structure and other represent the whole lung capacity. So that's why when we calculate DLCO is equal to KCO into alveolar volume. So each alveolar unit transfer efficiency into total alveolar volume is diffusion lung capacity. So this KCO and diffusion lung capacity, DLCO, both may go hand in hand or both may have a divergence. What it means that either the DLCO and KCO both are reduced, or you may see one of them is reducing, other is not. Right. So as Dr. Mansi pointed out, the transfer factor is more important than the diffusion. So when there is a parenchymal abnormality and the vascular abnormality, or any of the transfer factor is affected, both the DLCO and KCO will go down. But if there is some extra parenchymal abnormality, or in case of lobectomy, so the DLCO may go down, but the KCO may remains normal or increased, because the capillary flow, the blood flow is there, and there is a decreased alveolar volume. So it may increase, or the KCO may remains normal. So they may show divergence in extra thoracic problem, but they go hand in hand in case of parenchymal or vascular abnormality.
Yeah, excellent points, Dr. Girish. And to Dr. Srikanth, before interpreting the DLCO, what are the important things that one has to see in the report to make sure that the DLCO is of factual value rather than some interpretational error?
It is very important in our daily practice, because DLCO is very sensitive test, but it is technically also highly dependent on the technique. So it should not be interpreted blindly by seeing the report of DLCO that is decreased immediately. So whatever the acceptability criteria that were discussed in the talk should be fulfilled. Like the minimum quality checks that we'll do will be adequate inspired volume is there or not, or rapid inspiration less than 4 seconds as documented in the acceptability criteria, and breath hold, is there adequate breath hold is there or not, and there should not be any mouth leak should not be there, and patient should not pant or do any other unnecessary Valsalva maneuver or something like that, and it should satisfy the repeatability criteria also, including the your hemoglobin correction. So whenever we see a falsely low DLCO, it is a double-edged sword. Means you may unnecessarily ask for the evaluation of an ILD or pulmonary hypertension or emphysema. Maybe this patient is a completely normal patient. Or in opposite hand, a true low DLCO you may miss. It may be the earlier disease that you can find before you get changes in your lung volume or any other PFT abnormalities. So it should be interpreted very carefully, a low DLCO, by following these quality checks.
Yeah. And to Dr. Sumita, whenever you see a low DLCO, I think you did give a good algorithm for interpreting it, but just for the interest of audience, low DLCO, how do you approach this question?
So it's a very important clinically relevant question. As already Dr. Srikanth said, that you have to take that with a pinch of salt, whether those factors were corrected or not. Once you've seen that you don't have a falsely low DLCO, then move on to interpreting this DLCO. With a DLCO low and a normal PFT, the first thing that should come into your mind is whether this is a pulmonary vascular disease, whether there is a pulmonary artery hypertension or embolism present. Work on those lines for the patient, get a D-dimer, get an echo done. Other condition in which this can happen is an early ILD or early emphysema, the early obstructive airway disease, where your PFT may be normal and you're still getting an early low DLCO. So look into these kind of conditions, but the first thing that you should see is a pulmonary vascular disease that's coming.
So to Dr. Nitesh, I think extending from that same interpretation by Dr. Sumita, so how should we interpret a disproportionate fall in DLCO when the fall in FVC is not that high in a patient with an ILD? So what would you make, what thought process do you have when you have a disproportionate fall in DLCO? I think Dr. Nitesh, are you there? So I think I think we lost Dr. Nitesh. So basically, again, when you have a disproportionate fall in the DLCO, then always think about vascular pathology. So these ILD patients can have sometimes coexistent severe pulmonary hypertension, which may cause disproportionate fall in the DLCO in comparison to the FEC. Similarly, for patients with CPFE, whenever you have a CPFE patient, you can see that the DLCO being disproportionately low, and that may give you an even before you do a CT scan, you find the X-ray to be not so bad, but the DLCO being extremely bad in a patient with COPD, that could be a part of a CPFE or a combined pulmonary fibrosis and emphysema. So sometimes your disproportionate DLCO can indicate either a part of a CPFE or even a part of a severe pulmonary hypertension in a background of an ILD. So now moving on to Dr. Mansi, in COPD, does low DLCO only indicate emphysema, or should we also think about a pulmonary vascular phenotype?
Yeah, so as again the thing has been pointed out, so DLCO we are measuring both the components, the alveolar capillary membrane stability. In severe emphysema, there's loss of pulmonary capillary vascular bed also. So it will tell us about the severity of the disease, the DLCO. But additionally, if there is out of proportion DLCO impairment in comparison to FVC loss, then we have to think of pulmonary vascular involvement, which could be in the form of not only just the loss of vascular bed, it could sometimes indicate a development of pulmonary hypertension, and sometimes you can pick up early cases of mixed phenotypes, or they may be having some additional restrictive pathology like a CPFE, and sometimes incidentally you can detect chronic thromboembolism or maybe any pulmonary vascular disease. So out of proportion DSCO may tell you more about emphysema phenotype.
Yeah, and to Dr. Girish, since we are speaking a little bit about CPFE, why can spirometry and lung volumes be deceptively normal in a patient with CPFE? Because we have two different pathologies in the same patient. So would it make the PFT less reliable?
Yes, definitely. These two pathology, one is obstructive, one is restrictive. So they both counterbalances each other. With restrictive pathology, you have loss in the lung volume, and with compensatory hyperinflation or overinflation or obstruction, you have increase in the lung volume. One causes decrease in the elastic recoil of the lung, other causes increase in the elastic. So they both counterbalances each other, and that may be the reason that your PFT, FEV, and FVC ratio, they all remains the normal. You may not get change in the volume, you may not get change in the resistance or wall, because they're all counterbalancing each other. But if it is emphysema, if it is fibrosis, then the diffusion part is affected. So a normal looking PFT, a normal looking volume with affected DLCO, CPFE, as you have already been pointed on for the past 2 to 3 minutes, it is one of the main reason that CPFE may be a part of reduced DLCO with a normal spirometry.
And to Dr. Srikanth, how useful is VA by TLC comparison in real world DLCO interpretation?
By TLCO, what we can say is it can be a bridge between your body box and the DLCO. If one word we had to summarize what is it means, it tells us whether the lung volume measured by the body box is actually participating in gas transfer or not. Because we have to understand the VA, accessible alveolar volume. It is not alveolar ventilation, it is accessible alveolar volume. How much is the participating in a single DLCO breath maneuver? But your TLCO is absolute thoracic compressed gas volume, whatever is present in your thoracic gas volume. So it is very, very important in the DLCO interpretation. When you see the DLCO is low and your VA is also low, you have to differentiate whether it is because of your obstruction physiology or it is because of restriction physiology. To differentiate that point, your VA by TLCO will be very, very helpful.
Yeah. And to Dr. Sumita, like we are interpreting all this DLCO and everything using lower limit of normal value. But is there any other score which can be tried, like a Z score or a percentile? Like, how do you, which one would you choose to be a better indicator? Dr. Sumita, you're on mute. You're on mute.
So most modern pulmonary function tests are now increasingly shifting from your fixed percent predicted cutoff. So earlier we used to see those percentage predicted ones, but now we are moving to either lower limit of normal or the Z-score based interpretation, mainly because they are statistically more accurate. They have reduced misclassification related to your age, sex, height, and ethnicity. So your more accurate versions would be either taking lower limit of normal or the Z-score interpretation, then your either the percentage predicted cutoffs. So yes, let's move on more to Z-score. There are more accurate ones now, and it's important that we start reading them in the true sense.
Yeah. And to Dr. Nitesh, one last question before we take the audience question. Is there any role of combining DLNO plus DLCO in differentiating alveolar capillary membrane disease from a pure vascular abnormality?
Right, so NO is at least 250 times more diffusible than carbon monoxide. So practically it takes out the issue which is related with the membrane diffusion, and it just gives you the vascular thing. As well as DLCO is affected both by the membrane thickness as well as the flow across the membrane. So DLNO may be, so both, when both are used, we may be able to identify the exact process. Either it is the membrane issue or the vascular issue which is causing the problem to the low DLCO.
Yeah. So I think in the interest of time, we'll start taking the audience questions. We have a lot of audience questions today. So a quick answers from the panelists and the speakers here. So we have a question from Narsingh Rajpurohit from Jodhpur. This is to Dr. Sumita. He's from your town. So how reliable is pulmonary function test in a dyspnea patient? Very quick answers.
Yeah, so in a dyspneic patient, if you do a spirometry, it may not be completely interpretable, but we can do certain tests in which they don't have to do a deep inspiration, deep expiration. And in those cases, some tests like your impulse oscillometry, the DLCO, I mean, these kind of things, even maybe not DLCO, but impulse oscillometry may come really helpful in these patients.
Yeah, and to Dr. Nitesh, Dr. Navya has asked a question, how often do DLCO in follow-up of bronchiectasis be really helpful?
So bronchiectasis, we consider it as an airway disease and not as a parenchymal disease. So DLCO in bronchiectasis follow-up will only be affected when it is a severe bronchiectasis affecting major part of the lung. In the routine bronchiectasis, DLCO role will not be there. It will be more of lung volumes like RV by TLC, where we may see air trapping because of obstruction of the bronchi.
Yeah, and or maybe sometimes if you want to do a transplant evaluation, then maybe that may come handy. Yeah, to from Cyrus Sharma from Indore, how does bronchial artery hypertrophy affect DLCO? Maybe to Dr. Sumita again.
Yeah, so if there is a localized bronchial artery hypertrophy, then it may not really affect your DLCO because that may not change the overall pulmonary vasculature. But if that is causing hemopsis, having blood in your lung capillary membrane, yes, that will increase the DLCO. So you have to again understand what is the clinical scenario here, what is the CT picture, and that's how you interpret DLCO in these cases.
Yeah, and to Dr. Girish, sir, Dr. Hitan Chaudhary from Guwahati, role of DLCO in unexplained dyspnea. Yeah, very good question.
With this, yeah.
So I think it is a very important role when you are evaluating unexplained dyspnea. And by unexplained dyspnea, I assume that your spirometry is normal. There is no, you have ruled out obstruction. You have done the body box, and there may be a restriction, or there may be a completely normal body box with decreased DLCO. So as we have been discussing through and through, if the spirometry or the body box are normal and DLCO is decreased, then it is most probably a vascular pathology, maybe a pulmonary embolism, maybe a pulmonary artery hypertension. So taking into consideration unexplained dyspnea, hemoglobin has been taken care of, obstruction has been ruled out, there is nothing in the CT, there is nothing in the X-ray. So DLCO may points towards a pulmonary vascular pathology.
Yeah, excellent. So for unexplained pulmonary hypertension, maybe your DLCO may be the first marker which we are looking for. And Dr. Ganjendra Singh from Delhi, role of DLCO in hepatopulmonary syndrome to Dr. Srikanth.
So in the hepatopulmonary syndrome, because of our intrapulmonary vascular dilatation, the DLCO will be definitely decreased. But DLCO doesn't have a role in the diagnosis or in the follow-up. So, for example, if we can see in a opposite direction, maybe in a patient of cirrhosis where you look for the DLCO, in those cases, patient presenting with dyspnea and platypnea, orthodeoxia, your DLCO may be helpful in getting a differential diagnosis rather than a direct diagnosis in a case of HPS.
Yeah. So, and from Dr. Aisha in Mysore, how soon after pneumonia can DLCO be done? To Dr. Nitesh?
Right. So any radiology takes at least 8 to 12 weeks. So something like this physiology should also be done only after 8 to 12 weeks when the complete resolution of pneumonia and you can get the actual picture of the baseline lung.
And to Dr. Mansi, Mrs. Meda from Bangkok. If a patient only manages 2 acceptable maneuvers instead of 3, how does that affect the reported DLCO value?
So technically, we should be having three acceptable maneuvers. But if your both the loops are basically within the repeatability criteria, and the patient has performed them well as per the technical standards, then you might accept the value for clinical interpretation.
Yeah, and Mr. Aniket Bosle from Bombay to Dr. Sumita, minimum washout volume for DLCO.
Sorry, just a minute. Minimal washout volume for DLCO.
Yeah.
So the earlier, you mean to say the dead space volume that we are saying, right?
Yeah, I think
so.
so.
It is a
Yeah.
dead space thing. So it is the first early few seconds that is taken. So it is not really the volume, it is the first few seconds that is taken, that is washed out. Yeah.
Yeah. And Mrs. Mehak from Mumbai, what hemoglobin level needs DLCO correction? To Dr. Srikanth.
Mostly the reference equation says for the men around maybe less than 13, for women around 12. So these are the ATS reference assumptions in DLCO. If this is less than those values, we need a correction for the hemoglobin.
Yeah. And Cyrus Sharma from Indore to Dr. Nitesh, what is DLNO and how is it different from DLCO?
Yeah, so as we close out the discussion with this, DLNO is by nitric, which is more diffusible than carbon monoxide, 250 times more. So it takes out the component of membrane thickness. It just gives you the vasculature answer. DLCO depends on thickness as well as the vasculature. So this is how we use DLNO.
Hello. So can you hear me?
Yeah.
Yeah. So Dr. Atif from Mumbai, why does body plethysmography overestimate lung volume in severe obstructive airway disease?
This
I
we
think,
we have taken this already.
Covered this question, sir.
yeah. So, Dr. Sharwari from Mumbai, what are the normal predicted values for DLCO? To Dr. Sumita.
Normal predicted values, as we already said, the range I had already covered in my presentation, mild, moderate, and severe. I can just go through that again if required. I'll do that. I'll also share the PPT if required.
Yeah, and I think we have lots of questions. I think now we are going to have the rapid fire to the panelists here.
Yes.
So very quick answers, one word answers maybe. To how does anemia affect DLCO values? To Dr. Srikanth.
Anemia mainly lowers the DLCO. One word.
And Dr. Akshita, how do obesity and ascites affect expiratory reserve volume? To Dr. Girish. I think we lost Dr. Girish. Can Dr. Nitesh take it? Like how does
obesity and ascites both reduces your ERV and tidal volume by maintaining and keeping the TLC remain same.
Yeah, and to Dr. Mansi, explain the role of chest wall compliance in determining FRC.
chest wall compliance is basically it makes the lung move outward. So any chest wall reduction, the compliance goes in terms of obesity or anything, your FRC is going to be affected by that.
Yeah.
Obesity or any other problem with the chest wall.
Yeah, Dr. Sumita, why is ERV often the earliest abnormal lung volume in obesity?
Can you repeat the question?
Why is ERV, expiratory reserve volume, often the earliest affected lung volume in the obesity?
Because what we are doing in obesity is as Nitesh already said, that your total lung volume will remain the same, but your tidal volume affects.
Yeah.
So
I think,
yes.
Again, how does polycythemia alter DLCO? To Dr. Nitesh.
We already covered that one as well. Yeah.
Yeah. Okay. Anything different? Okay. Okay. This is to Dr. Nitesh. Why is KCO often elevated in kyphoscoliosis despite a reduced DLCO?
It's because the alveolar units get affected. So if your denominator reduces, your ratio increases.
Exactly. Yeah. And
yeah, I think I covered that particular part in the presentation again. The KCO is determined by VA upon DLCO. So your VA is decreased, but your DLCO is, only VA is intact, but your DLCO is marginal decrease. That's how your KCO is normal or increased in that case.
Okay, I think the questions are so high. We have, okay. Explain the significance of reduced FRC during anesthesia. Dr. Srikanth, you want to take it?
Reduced FRC. Okay. So whenever we give the anesthesia, so it will paralyze the all conscious and all respiratory voluntary muscles of this thing. So automatically your as a part of that, your diaphragm is also will paralyzed and leading to a low in the functional residual capacity will be lowered.
Yeah.
And because of the position of the patient also.
And to Dr. Mansi, how do pregnancy-related physiological changes alter lung volumes?
So pregnancy, most importantly, that your FRC reduces because your ERV and RV reduce there, but because there is an increase because of the hormonal influence, the chest wall compliance also gets better. So overall, due to the FRC goes low, but the TLC is by and large preserved, and patient is used to hyperventilation, so that preserves the normal physiology of ventilation.
And to Dr. Nitesh, how does small airway disease affect lung volumes before spirometric abnormalities appear?
Before the spirometry abnormality, small airway disease may increase the airway resistance or decrease the conductance, and it also increases your RV by TLC ratios.
Okay, there's so many questions I've seen. Okay, to Dr. Srikanth, what is pseudo restriction and how is it different from true restriction?
As we discussed, your FEC will be low, but your TLC will be normal. And sometimes you need to check for the RU by TLC, which can be high. So that restriction may not be because of the true small lung. It is just the hyperinflated lung unable to breathe out.
Yeah, and to Dr. Nitesh, explain what causes hockey stick pattern appearance in body box.
Right. So hockey stick pattern is something where the ends are broader and the whole loop remains within the range. So it is seen usually in the obstructive cases where there is either a fixed expiratory obstruction, then you will get the expiratory. There is a fixed inspiratory, then you will get the endo-inspiratory loop. And if it's a fixed obstruction in subglottic space, you will get the hockey stick at both the ends.
And Dr. Sumita, how does smoking affect DLCO testing and how long smoking should be stopped before you go for a DLCO testing?
So again, what smoking does is it increases the carboxyhemoglobin value in the blood itself. So if already carbon monoxide is present in your blood, the inhaled carbon monoxide will have decreased binding sites on the hemoglobin. So that's how your DLCO interpretation will be falsely low in these patients. So you tell your patients to at least stop smoking 12 hours before the test.
Yeah. So one last question to Dr. Nitesh. What are the different methods of measuring lung volumes?
So as we had discussed, the body box remains the gold standard. So there is FRC pleth, FRC helium, FRC nitrogen washout, single breath helium, multiple breath helium, and so these are the methods to measure the lung volumes.
Yeah, and
I
yeah, ma'am, please go ahead.
Yeah, there are two good questions I can see. One is, how do you identify a leak in a DLCO test?
Yeah.
So, so when you're doing a DLCO, in the exhalation should be a very smooth curve. If you can see a sudden fall or a jagged curve, that's how you know that there is a leak happening, and you check your, the cylinder which is providing the gas at that point of time. And another question is that when will you do a multiple bed DLCO as compared to single bed diffusion? So there are certain conditions in which the ventilation is not homogeneous, it is heterogeneous, especially in cases of emphysema. In such cases, when you want your multiple breaths to have an equal dilution of the air in the lungs, in those cases, like your emphysema, you can use your multiple breath DLCO instead of a single breath test.
Yeah. So I think we have covered most of the pertinent questions, and I think we have already overshot the time. And as I see from the organizers here, there are almost like 2006 audience who have interacted during this panel discussion and question and answer session. So without extending it further, I would like to express my thanks to each of the panelists here and to the speakers for accepting the invite and being a part of this web meet. And thanks to ICS again. And thanks to Dr. Amita Nene for her steadfast efforts in conducting these academic meets, and to the organizers, SIPLA, especially Mr. Vipul and Schiller, for coordinating this web meet, especially Mr. Amit. So I think we learned, I wouldn't say a lot, but at least a little bit about body box and DLCO, because this is a topic which is huge and which covers essentially the entire physiology of lungs. And I think with this knowledge, at least I feel like most of us will be equipped enough to start interpreting the DLCO and the body box values in a much better way, and probably start using it for your patients as well. So thank you once again for being a part of this program, and to all the delegates as well, and wish you a good day, and most probably we'll catch up for some other academic meet soon. Thank you.